Welcome, everyone. My name is Brad Siff. I'm the founder and president of BioWave. This is our 8th webinar, and I would like to welcome our guest lecturer, Dr. Ted Arkfeld. Ted is a leading sports medicine-focused chiropractor, and his presentation today is titled Treating Pain with BioWave in a Neurologically Based Chiropractic Practice, Protocols and Case Studies. I'm really looking forward to this presentation. Please remember to stay around at the end for the live Q&A session, and please remember to use the Q&A function at the bottom of your screen. With that, I would like to introduce Dr. Arkfeld.
All right. Hello, everybody. I'm Dr. Ted Arkfeld, and I am the clinic director of Arkfeld Advanced Chiropractic. And I'm very excited to be doing this webinar today on BioWave. I first purchased BioWave, I believe it was 2016 or 2017, and it has been instrumental in our clinic. And I have a unique office because I see chronic pain patients in the morning, and then I see a lot of sports-related injuries in the afternoon. And BioWave has been a main component in our battle against pain. So I'm going to go over a few case stories today. So this is just a real brief background. I am a 1988 graduate of Northwestern College of Chiropractic. I did get my BS degree in human biology. And then about 8 years later, I decided to go back to school and got a Master's of Science in Biomechanical Trauma from Lynn University in Boca Raton. I have worn a couple different hats besides being a clinician. I also have spoken at great lengths for many years on the importance of documentation and coding, and then linking the two with clinical expertise. And then for the past 20 years, I've been a volunteer team chiropractor for Gaylord High football team, basketball team, soccer, you name it, I've done it. And I continue to serve in that capacity as well. One of the reasons that I did bring BioWave on is that I wanted to give our athletes a competitive edge. I wanted to be able to get them back to participation as quickly as possible, and it has allowed me to do so. Treatment philosophy, it's very simple. We treat pain, but I want to treat pain and increase performance. So we are a neurologically based chiropractic office focusing on enhancing neurological performance of the brain and spine. What does that mean? Basically, our bodies are full of receptors, and those receptors send signals to our brain. And so with any type of injury, there can be nociceptors that are turned on causing pain, but the brain can also not receive the correct information or actually become neurologically starved. And when that happens, you don't have good input, and that's going to equate to bad output. In other words, abnormal movement behavior. And what BioWave has allowed me to do is to get those signals turned on, and we call that afferentation, which is the sum of all the sensory information going into the brain. So we are able to take patients who, and I call them neurologically starved or deafferentated, and we're able to do afferentation. And BioWave is one of our main neurological stimulation therapies that we use. So we use BioWave with chronic pain patients, sports-related injuries, and acute pain. I want to go over a case study, which is a post-surgical low back case study today, or Melissa's story. Melissa presented with a chief complaint of lower back pain with radiating pain down the right posterior thigh all the way to the dorsum of her foot. This actually had started in January after she had visited her chiropractor, and he performed a side posture adjustment without conducting an examination on her lower back. Over the ensuing hours, she began to experience sharp and stabbing pains in the low back. And she began to experience loss of strength and more pain, unbearable pain, going down her leg. She was seen at the local ER and was immediately scheduled for a lumbar spine surgery after the MRI revealed a disc herniation, a substantial one, at L5S1. So she underwent a laminectomy, and for about 1 week, her symptoms eased up. A week later, the incision became infected with staphylococcus, and a second surgery was performed to clean out the infection. Ever since then, she has had moderate to severe low back pain, even with one round of physical therapy and with pain management of epidural steroid injections. So her review of systems, unremarkable. Past medical history, like we said, surgery, L5-S1, laminectomy. Past chiropractic care. She had not seen a chiropractor since this happened. She is a single mother, school teacher, and her life was upside down. Orthopedic tests. Now, I'm not going to go into each individual orthopedic test, but to say that all the compression tests were positive for radiating pain into the right lower extremity, as well as pain in her lower back. Dermatome evaluation revealed right hypoesthesia in the L5 dermatome. S1 was normal, and vascular examination was abnormal in the dorsalis pedis artery and posterior tibialis artery. So what had happened is that this whole injury, this whole surgery, this whole episode had tossed her life totally upside down, and she is extremely stressed out. It's called a sympathetic survival syndrome. Part of that is just a constriction of the blood vessels, and I believe this was responsible for the lower extremity pulses to being abnormal. Spinal exam, severe pain and tenderness, hypertonicity, misalignment. L4, L5 wasn't moving like it should. Midline scar from L3 to S1. So the differential diagnosis that I was looking at with her was, is this totally from the sacroiliac joint? Is it still part of the disc? Is it a facet joint? Is it radiculopathy? Actually, it was all of the above. So what I learned right away in dealing with Melissa is that I was going to need to differentiate my approach. Pain can be learned by the brain and persist long after an injured tissue is healed. And this is where we may be able to help where other approaches have not. So by the time Melissa got to me, it was 2 years post-trauma. And she'd gone through the round of PT, the epidurals. And so the question remained, why was Melissa still in pain after 2 years? Why was she still having low back pain, pain radiating down the leg, when the surgery, for all apparent purposes, was successful? The surgery for the staphylococcus, the infection, was absolutely good. Everything was fine there. So why was she still in pain? Well, it's basically because her brain, a part of her brain in the parietal region, like right up here, called the sensory homunculus, was not receiving information from the anatomical structures in order for it to get out of DEFCON 5, as I call it. So the information wasn't getting up to the parietal area. And so the brain had lowered the threshold for pain. So anything that she did was going to cause pain. That was one. It's called centralization. Two, there was some peripheralization. There still was some mechanical issues in the lower back. And then she had developed scar tissue, which I believe was responsible for chemical radiculitis, more inflammation when she would move, maybe tear a little the scar tissue up. But what was happening is that she didn't have good sensory motor control. She didn't have the information coming up, which created a lack of muscle movement control and therefore a lack of plasticity in her brain or the neural networks. So what we had to do with Melissa is change the focus. I had to change it from more of a mechanical or structural or bone out of place that you'll hear a lot of chiropractors say. I had to change it more to a neurological, more to a brain-based type of causation for her symptoms. So we had to talk about what is the dominant pain mechanism. Well, whenever you have any of the receptors that reach a certain threshold, they turn nociceptive. They turn into pain receptors. This is where BioWave is crucial. And it's the best thing that I've ever seen. And especially for a provider like me who is we don't prescribe medications, okay? So what are the tools that I need to get patients out of pain? Well, BioWave takes and it forms a force field over those nociceptive tissues, and it really blocks those signals from getting into the spinal cord and then on up to the brain. So I did talk to her about that. I talked to her that she still has peripheral neuropathy from the scar tissue. And then a big part was the central pain mechanisms. So what she told me was, I don't even know what I'm doing here. You know, a chiropractor did this to me. I don't know what I'm even doing here. What are you going to do differently? She was actually depressed and anxious and a little angry. And I said, well, what are you doing here? Why are you back at a chiropractic office? She said, well, my sister and other teachers tell me that if you can't help me, nobody can, because you have state-of-the-art therapies in your office that's used at the pro level and by major sports medicine departments. And I said, we do. And I'm thinking of the first line of defense right away that we're going to attack your pain with. And I talked to her about BioWave. So I told her that our whole goal was to decrease the pain and get her moving. We had to do that in a very safe and efficient manner. And one of the techniques that I use is called Cox flexion distraction technique, and then using BioWave with that. I actually did a YouTube video with that for BioWave. So check that out, because it really is effective in increasing range of motion, flexibility, but it's huge when decreasing pain. So this is what we did with Melissa. Here's the clinical outcome. She started sleeping throughout the night within about a week. Pain levels went from a 7, and I mean a constant hard 7 throughout the whole day, down to a 2. She increased her activity. She started working out at the gym, taking hikes. She started enjoying her life again. Anxiety and depression were gone, and she said she had her life back. Okay, so I attribute this to many things, but the number one thing that we did was with BioWave as the forefront in our treatment tools that we used. So this was a very interesting case study, cerebellar degeneration. This is Roger's story. Roger presented with lower back stiffness and soreness, but he was constantly blinking, slurring of his speech, balance issues, just not good. He had been under the care of a neurologist at the University of Michigan who diagnosed him with cerebellar ataxia. What that means is that his cerebellum, which is such a beautiful thing that we have up in our brain, the cerebellum is responsible for posture, movement, proprioception, balance. But here is where it plays a huge part with low back conditions. The cerebellum is responsible for the intrinsic tone of the multifidus muscles, or the intrinsic muscles that attach right to the spine. Those muscles, if they become weak or atrophy, will not send signals up to the cerebellum. Patients will not have good proprioception. It actually can create an instability, and I think it sets the mechanism of injury for further disc involvement. At any rate, Roger was not functioning well, and his cerebellum definitely was not functioning well. So this is Roger when he first came in. So I want you to look, see how he's swaying back and forth, hands on the hips here. Look at him go back and forth. He's neurologically starved. Cerebellum not working like it should by any means. So what did we do? Spinal manipulations, BioWave sessions. We did Normatec and Brain Tap. Normatec is compression therapy. It helps with the circulation. Brain Tap is something that we use for autonomic nervous system, because this was stressing him out. And so it was just a way to calm him down. In about 19 visits, this is what we saw with Roger. Look at that. Okay, so what did we do with Roger? We applied BioWave to the lumbar spine. I did Cox flexion distraction technique again on there. So what the BioWave did initially, it was get down to the nociceptors and block the pain. But what I think it did after that is that it reached down into the not only the superficial muscles, but it went down into the multifidus muscles, and it opened it up. It created afferentation. It created those muscles to start firing up to a cerebellum. It was like we reawoke Roger's nervous system, and this was the end case. I'll never forget one day he came in and he said that he went jogging for the first time in years. And then one day he comes in and he said he was riding a bike, and his wife came in with him on his final examination, final visit, came in, and his wife started crying up at the front and just said we gave her husband back to her. And it was just, she was just amazed at it. So this is why I became a doctor, to help patients like Roger, to help patients regain their life. And again, these are just 3 case stories. I could go on and on and on with the effects of BioWave and what it's done for patients in my practice. Now, this one is more sports related. This is a case study number 3, chronic tendon pain. So Jake is an 18-year-old football player. Well, he was. This happened a few years ago when he was a senior in high school. And he presented with right inferior gluteal region pain that he pointed to was localized between the ischial tuberosity and his hip joint as a site of pain. His initial injury came in the spring during a track meet when running the 400 meter. As he started to accelerate, he described a pulled muscle sensation and immediately eased up for the rest of the race. For the next few weeks, he rested, applied ice to the area, and slowly began to work back into running. Over the ensuing weeks, every time he attempted to go full speed, he felt pain in the right posterior thigh and hip. He changed his warm-up routine to a more dynamic approach, stretched vigorously, following practice, before practice. And while there was some improvement, he kept feeling soreness and pain when attempting to go 100%. After track season was over, he was seen by his family physician, who ordered PT. He was seen for 4 weeks with ultrasound, laser therapy, and stretching. Again, some benefits being achieved, but he still felt there was discomfort there. Now, football season rolls around, and in August, after our two-a-days, we do a live scrimmage. And so it was during this live scrimmage that he caught a pass, and after running down the sideline, he felt what he described as another pulling sensation. He immediately went out of bounds and then came over to the sideline to see me for an evaluation. And there was tenderness to palpation in the right gluteal region, increased pain on flexion and adduction of the hip and buttock region. And once again, went back to his family doctor, ordered PT, and went through another round of PT. He continued to play football, but every game he complained about right hip pain. And he had been going to PT 3 times a week for 2 weeks, but there was no improvement. He was sent for an MRI, the lumbar spine and the right hip area. There was some mild degenerative changes at the L4S1 disc, but no other significant pathology was visualized. The degenerative changes were not the causation for his pain. There was also no evidence of injury to the hamstring tendon or other proximal muscle tenderness. Or tissues, I'm sorry. So what's causing this? What's causing Jake's pain? Well, was it the disc? No, it wasn't the disc. Was it the SI joint? Maybe a little bit involvement there. Was it a facet joint? Maybe. But I think it was more myofascial in duration and in nature. And tendon. So there's definitely a tendon issue there. So Jake was really having some, he initially had what we call a tension loading on the tendon going to one of his gluteus maximus, medius muscles, and some other rotators of the hip. He also had tendinosis. Okay, tendinosis is when there is there's pain. Tendinopathy is when there's pain, but there's also clinical features of some damage to the tissue. Now, in Jake's case, there was no tendinopathy because there was no damage on the MRI. So why had his symptoms become chronic? Well, it's again because those anatomical structures were not firing up to Jake's brain. And so there was a decrease in the threshold for pain to occur. Jake also started focusing on that. And so he had been told, oh, you've got a hamstring problem, oh, you have maybe a disc problem. And he became those problems. And that's one of the issues that we really have to face if they've been seen by numerous providers and they've been told you are your MRI, you are your X-ray. And they're not. We have to de-educate and re-educate the patients. So I told Jake, I said, listen, we're going to handle things a little bit differently here. We're going to come at this differently. Everybody's been going at this from a mechanical and structural point. We're going to go at it from a brain perspective. And what this means is that it's not in your head, but you're not getting the signals again from the hamstring and that area up to the brain. So he had pain, absolutely. So one of the main things that we did is, again, we applied BioWave to that area. So the BioWave did two things. First of all, it created the bubble, the force field, to stop the nociceptive input. It also allowed us to get in there and get Jake stretched and moving, but it also created a neurological stimulation. So information was getting up to the brain, and the brain said, okay, we're finally getting information. We understand what's going on there. So it raised the threshold before any symptoms would come on. So we just changed the focus. We still used BioWave, but we changed the focus instead of mechanical and structural. And Jake had an unbelievable year. So we restored the load-bearing capabilities to his muscles. We created afferentation to the sensory homunculus, and we created stress reduction because he was starting to, after the games and after practices, it was all focus, all my hip. And it was interesting because once he got into the game, he performed beautifully. You would never know there was any issue. So I knew that it really wasn't mechanical in nature, that we had to come at this from a different point of view. And I think that many times as providers, we do become too structurally oriented. We do become too mechanically focused. And that's why I call it a neurological basis for our therapy. And BioWave is number one on that. So our treatment, spinal manipulations, BioWave therapy. We applied rock tape, Normatec, and brain tap. Proud to say that Jake is now playing down at Taylor University. This would probably be his third year down there. He's a starter and is having a wonderful beginning to his junior year. So in summary, BioWave is our first line of pain therapy, but we also use it in another capacity. It's our first line of pain therapy, but it's also our neurological therapy as well. It allows us to get patients moving. That is crucial. We have got to get patients, number one, out of pain, and we got to get them moving. Now, I've got to go into my coding background and compliance background. This is the medical necessity for care that insurance companies are always talking about. Medical necessity states that we have to get patients out of pain and we got to restore them to their functional activities in the quickest time possible. What we need to do, and I'm talking about chiropractors here, we have what I think is an outdated business model in chiropractors where we rely too much on passive therapy, where the patient just comes in and we do all the work. BioWave allows me to get them active. I can put the pads on, maybe put a wrap on, and I can get them on a treadmill. I can get them doing exercises. It allows rehab. And when we can do that, now we get those tissues firing and we start the process of afferentation. So I would recommend to any chiropractors out there that if you want to get superior clinical results, get BioWave and start adding active rehab into your clinic. And you're going to see some amazing results. And, side benefit, you'll give yourself a raise as well. So with that, I will open it up to any questions.
Thank you very much. That was a great lecture and webinar. If anyone out there has any questions for Ted, please use the chat box at the bottom of your screen. The Q&A box at the bottom of your screen. And we'd be happy to answer any questions that you have.
Do you use BioWave before or after chiropractic sessions? Is it a standalone session without having other treatments that day with the doctor? That's an excellent question. Because I am attempting to reestablish neurological performance for a patient, I'm always going to do a chiropractic manipulation. It just depends on the technique that I'm using, but I always use that in conjunction with the BioWave and with our active rehab. So we find we get the best clinical outcomes with the patient by layering those type of treatments. And that's what I call it, layering. We're just constantly building with a neurological input from everything that we do.
Thanks, Ted. The next question is, how many times do you recommend, how many times a day do you recommend using BioWave?
I love this question, and I'm sorry because I just got really excited about it. We have, I can't remember how many BioWave Goes, which is the smaller home use. And what we started doing with our patients is that we dispense that out and we do a nominal fee per week. When the patients are coming in, we ask them to use the BioWave Go in conjunction with the BioWave we're using in the office. We have the BioWave Pro. So they'll get a session in our office. And then when they go home, I said, wait an hour. Then I want you to use the Go. Wait an hour, use the Go, and get as many sessions in that you can. Because what we found is that will get them out of pain and increase their function as quickly as possible.
Thank you. We've got several more questions. Can you tell us about the actual BioWave treatment you used? I'm not quite sure. When you were using BioWave in your office, you're using a BioWave Pro device. I would just make the comment that the electrical signal technology is identical across our entire product platform. So whether you're using BioWave Pro or BioWave Home or the smaller wearable BioWave Go, it's the exact same treatment. So if the patient's getting treated in the office with BioWave Pro and they're using BioWave Go at home as an example, they're getting the identical treatment. I'm not sure if that was the question that this person was intending to ask, but that's how I'm interpreting it. The next question is, being unfamiliar with BioWave, are there different protocols or programs on the unit, or is it an on-off system? If you don't, Ted, if you don't mind, I'd like to answer that question. So when we developed the original BioWave technology, we discovered there was an optimal set of high frequencies for delivering energy through skin into deep tissue, and this was from our first dosage study that we ran on chronic low back pain patients at Weill Cornell Medical College at New York Hospital. And then in the second phase of that study, we discovered there was an optimal, if we could get the body to produce an electrical field at a particular low frequency in the body, it caused the greatest reduction in VAS pain scores from before to after treatment. So the results of this early clinical trial allowed us to design a really simple to use device. There's no program. The waveforms of the high frequencies and the frequency at which they operate are fixed. The only thing that's controlled is the intensity, it's the voltage, and the patient controls their own comfort level by pressing a plus or minus button on the face of the device, whether it's in the clinic or at home. And because the active electrical fields form in a hemisphere beneath each of the two electrodes, the electrodes must be placed directly over locations of pain. Or if you have a radiculopathy, half an inch over the spine, half an inch in the direction that the pain is radiating, and the second electrode is placed in the most proximal location of pain next to, relative to the origin. So it makes for an intuitively simple device to use, both from an operation as well as from a pad placement standpoint. So I hope that's it's literally an on-off button and a plus-minus button. So very, very simple to operate. The next question is regarding chronic neck and shoulder pain. Deep tissue massage does more for me than manipulation. BioWave Home has taken my pain from 9 and 10s to 3 and 4s. I do 3 sessions back to back early in the morning for a better day. Do you recommend anything else? Person says, I love my BioWave Home.
The only thing that I would add to that is start doing some exercises. If you can go for a walk, if you can get on the treadmill, if you can do a stationary bike, put the BioWave on and start to do more activities, and you're going to even increase your results with that.
I couldn't agree with you more. Thank you. Then there's another question. Do you have a method to electrode placement? So I would just comment that, as I described in a prior response, I mean, essentially the electrodes are placed directly over locations of pain because the active electrical field is forming in a hemisphere. Think of like half of a grapefruit, about a 3.5-inch diameter hemisphere beneath where the 2-inch diameter electrode is placed at the surface of the skin. So that's why the electrodes are placed directly over locations of pain, because we want the active electrical field to encompass the pain nerves in the region where the pain's presenting. But Ted, I would, ask you, in terms of electrode placement, is there any particular method to how you go about it?
We follow the manual. We follow the manual just like you recommended. We don't deviate from that.
Okay. Okay, one person thanked us for the response. Here's another question. May I use this on patients with a history of cancer? So let me, if you don't mind, I can comment on that.
Go ahead.
So cancer is not a contraindication. It's considered a warning. So BioWave has been used on patients that have pain that results from cancer, but because the active electrical field causes an increase in blood flow, there's no data on whether that's moving cancerous cells around the body or not. There have been patients who are in hospice and they wanted to use BioWave as a treatment, and the treatment helped reduce the pain that they were having as a result of the cancer. And so maybe that is a good use. We would tend to be on the cautious side of using it on cancer patients. Electrodes must be placed directly on intact skin. You can't place it over an open wound if the cancer is near the surface of the skin. So that's my commentary on it. You can use it. I would be cautious in how you use it on patients with cancer. We have another question. Can it be used over metallic implants? And the answer is yes. BioWave can be used over any type of metal or other hardware in the body. We did a study on total knee replacement patients treating pain postoperatively. Actually, we treated morning following surgery. So, and there's absolutely no issue with treating over any type of metal hardware, from rods and plates and screws in the spine to anchors or clips or anything of that nature. So that's absolutely totally fine. Just like I said before, the skin has to be intact when the electrode is placed on the skin in the region where the pain presents. If there's any other questions, we're happy to answer any more questions. Those were great questions. Thank you. That looks, I think that's it. So again, thank you very much for attending this webinar. This will be on our website under the webinars link if you want to tell any of your friends or colleagues about it, including the Q&A session. So again, thank you for attending. Our next webinar will be next month around November 15th. So we invite you to attend that as well. I believe we're going to have a pain physician from Yale who is our guest lecturer, talking about some case studies that he has been involved with. So thank you very much.